I'm delighted to introduce the chair for this session on the Lifecourse Health and Social Care, and that's Professor Daniel Davis, who's part of the MRC unit for Lifelong Health and Ageing, and works with the Institute of Health Informatics. Okay, Daniel, turn to you. Do you have the mic? No, you don't.
Thank you very much. Thank you very much. Thanks very much. So the session today is going to be talking about integration between social care and health, and I'll let my co-panelists, friends and colleagues, introduce themselves and do a little bit about their background, and then we'll have some discussion points that will try to outline some of the common issues around people who are interested in researching across both sectors, and then a lot of opportunities to take questions both from the room and online. So I'll start by asking Laura Sharp to introduce herself.
Hello, is that working?
Yes, great, okay.
Okay, so hi everyone, I'm Laura, I'm Professor of Public Health, I'm Director of the Institute of Health Informatics. And whilst I'd say my public health credentials are probably reasonably robust, I'm a bit of a newcomer to social care in that I've mainly done work in primary care and secondary care prior to the pandemic, a bit of work in care homes. But during the pandemic I set up the Vivaldi study, which was the main source of data on COVID in care homes to support the public health response. And so really since then, I have almost entirely been working in care homes and thinking about how we can learn lessons from the pandemic, and particularly thinking about how we can use routine data to try and get a better understanding of the interface between health and social care, and particularly care homes, and doing a lot of work with the care sector to understand where the gaps are and to work collaboratively to try and design the infrastructure that we need so that we can do research in that setting.
Hello. Hi everyone, I'm Jason Strelitz. I am the Director of Public Health and the Director of Adult Social Services in Newham in East London. For those who don't know Newham, it's a few miles to the east of here, a fascinating, wonderful, amazingly vibrant, dynamic, diverse place. I've been there since 2019, so I was Director of Public Health through the pandemic, and much to my surprise, took on the role of Director of Adult Social Services 3 years ago. So a bit like Laura, came into it not knowing an awful lot about social care, but have been on an enormous learning curve over the last few years. And we'll talk about that, but I also think in the course of the conversation, think about it in the context of public health, think about it in the context of ageing well, for example, and the links to the previous session. And yeah, really good to be here.
Thank you very much. I might kick off by just asking Jason to set the scene a little bit. I'm going to make the assumption that we're probably more health researchers by background in this room and online than social care. So I'm going to ask Jason to tell us a little bit about administrative data in social care, what local authorities hold statutorily, and just giving us a flavour of the data that are held by local authorities for social care use, potentially.
Okay. So, well, I put it in a bit of context about who. So we're talking about adult social care here rather than children's social care, just to be clear. So it's a relatively small part of our population. I think that's one of the first things to think about when we think about health and social care. Huge proportions of our population and huge proportions of our older population, most people in some way, shape or form will be using healthcare. Relatively small numbers of people draw on statutory social care. So in Newham's population, which the ONS says is around 370,000 people, albeit it skews a relatively young population, we support only kind of roughly 4,500 people formally through adult social care. So those will be the people, that will be our data, that will be the records. And so those are people who've had a Care Act assessment under the Care Act and are being provided some kind of formal commissioned care support. So that might be most of them will be receiving home care. A significant proportion will be living at home and receiving direct payments, and a relatively small number will be in some kind of residential care, either supported living or a care home. So that's the kind of context that we're talking about, yeah. And I think worth also remembering that whilst most, I think around kind of 80% of our care population are older people, a really significant part of adult social care is supporting adults of all ages, adults with significant disabilities that affect their day-to-day living, with learning disabilities, with significant mental health issues, and that's some people who transition out of being supported as children, young people, into being supported in early adulthood, and also people who develop social care needs throughout their adult life.
And then how does that also, other administrative data sets the local authority might hold, for example, on housing, or do you hold census data as well?
Yes, so we have, we are a landlord, for example. So we have data on the people who live in Newham's homes, but where Newham's a landlord. And we can link those two bits of data, although that's not necessarily as big a crossover as you might think. Newham has relatively low levels of social housing. Due to its history, it has quite a lot of housing vulnerability in poor owner-occupied housing and a lot of vulnerability in the private rented sector, where we've got a lot less data than we would around where we're the actual landlord. So we've got other data, so for example around housing benefit or council tax, where there are some limitations around how you're allowed to use that data and how you're allowed to the different purposes you're allowed to use it for. But yeah, we do have different sources of data that we are able potentially to do interesting linkage work with.
The reason I'm asking to paint that sort of picture is to get a sense of, if I approach local authority X or Y and, and are interested in, the mother of all health and social care linkage projects in one kind of social care and health data, health intelligence system, who do I even, what are the data sets to even request? I'm not, to me it's not as apparent as maybe from social care the other way. Laura, would you want to comment on the data sources that are held by people who are resident in nursing homes generally?
Yeah, so I'm also interested in terms of so that's local authority funded people, but certainly in care homes a very large proportion of people are self-funded. And so one of the challenges you have then is those people don't appear in any of those data sets. And so the approach that we've been taking is to instead work with the companies that provide electronic care records to those residential nursing homes, so that we're able to get information on everybody in the care home, not just those people who are funded by the local authority. And so a lot of this is about trying to just simply get the denominator right for the populations in these different settings. Because some of the things that we're really interested in is how people move between health and social care. And if you don't know who's in a care home or in social care, because you don't have that comprehensive view, that becomes a really difficult thing to understand. And recently, the Department of Health has started making available a data set called client level data, which is all based on local authority data. But one of the challenges they have is they don't know how many people they're missing. And so our goal is to work together to try and start answering that question.
It may be a surprise to people who don't do care home research that actually even in the health data set it's not apparent exactly who is necessarily in a care home from things like CPRD and so on. That's a huge innovation, Laura, to instead of trying to take the setting as in the nursing home as a unit, but to use the providers of the data set, the people who record the data, the health systems, the EMISs of social care essentially. From the frontline social care records, how are they coded and what kind of computer system do you use?
I mean, you're getting out of my specialist area, to be honest. It's not really the focus of. So, I mean, we have case management systems which our frontline social workers use to record assessments, to record their contacts with the people they work with. We use a particular system in Newham. It's not used widely across the country, the particular one that we've got, which probably isn't terribly helpful from a research perspective.
I mean, ultimately we are trying to think about how can any of these systems be leveraged for research purposes. But maybe it's worth just stepping back and asking, a broader question about prevention, where the CARE Act has performed duty on local authorities to delay or prevent and delay the needs for social care needs. Prevention is obviously an NHS priority as well. Where do you see the big opportunities for prevention locally or nationally?
Yeah, so again, I would be talking, again, care home related. We know there are so many avoidable hospital admissions in that population, huge numbers. My particular interest is in infections, so we see lots of people going to hospital for flu, urinary tract infections, and so there are lots of opportunities to do the standard public health interventions that are not rocket science, but things like vaccinating people, making sure they're getting the right antibiotics, making sure people are eating properly and adequately hydrated. So a lot of opportunities, but I think that one of the real challenges in these settings, certainly in care homes, is that people make the assumption that you have an equivalent workforce to the workforce that you have in the NHS, that you have lots of nurses, you have lots of people who are clinically trained, and you don't. You have people who have not had those kinds of opportunities very often, and so you can't just say to them, well, can you please make sure you only phone the doctor if the person actually has an infection. There's so much to be done about training and capacity building in that workforce to really realise those opportunities for prevention. So I think that there's so much that can be done, but we're really scratching the surface on that.
I'd agree with Laura on almost everything, apart from the bit that says that care homes are less well placed to do prevention. Well, maybe they are, but it's not that the NHS is doing the prevention it could do, despite its enormous assets. So I think there is masses we could do. And there's, people have talked about the importance of building prevention and really embedding it and growing it for a very long time. And that it makes complete sense. And you'll never find a conversation with anyone saying it doesn't make sense until sometimes you're in the conversation with your Director of Finance. But it doesn't need to be that way, because I think what Laura spoke to, and there are many, many other examples, and they were alluded to in the previous session by the presenters in the previous session. There are many, whilst we could take a very big picture view of prevention, a very Lifecourse view, and of course, if we were addressing the kind of structural determinants of health and well-being, that would be the best thing we could do. But there's so much that could be done in the short term where the payoffs are really, really quick. The stuff that Laura referred to, work on, that was mentioned in the previous session around, for example, physical activity, around falls prevention, around building social connection. And there's so much that we could do. And like I say, we are doing that. So we are really trying to do that within the department that I work in, that I lead. We have a rising demand. If we did nothing else, if we just care managed. So the most basic thing we could do in social care is someone, for example, has a stroke, they go into hospital, they're then discharged into care. We care manage. We assess them under the CARE Act. We try and understand what they struggle to do, and we put in care and support to enable them to eat, wash, meet those basic needs. If that's all we did, we would see an extraordinary rising curve of demand and need, because aging population, extended life expectancy, with not the same benefits in terms of healthy life expectancy, we would just see rising demand. But what we need to do is really flatten that curve of demand, and it is by prevention, and it's about using the range of both public health interventions, but also therapeutic interventions, so things like rehabilitation or physiotherapy, things that get people closer back to their baseline of good health before that crisis event happened in their lives. And what we're seeing is we're able to do that. We have in Newham, where I work, we have over the last couple of years coming out of the pandemic and really biting the bullet on this, really starting to flatten that demand curve. But there's much more we can do and much more we need to do. And I think the more that the care and the health system can do together, we will really start to realise the benefits. Have I got the good mic?
Yes.
I'm going to keep it.
Thank you. I'd like just to get to develop that a bit further, because you actually, in your job, in your role, have responsibilities for public health and social care. So, in terms of the unit of the local authority, what are the advantages that come with having, pretty wide brief?
So, one of the advantages, so it creates conflicts of incentives. So the advantages, I hold, a sizable budget, and from a social care perspective, I've got really strong incentives to invest in prevention. Because actually, one of the challenges in some parts of our public system overall is where one bit of the system needs to do the investment in prevention, but another bit of the system will gain the benefit of it. And there we're really weak as a public system, and we haven't worked out how to get over those incentives. But in my narrow little world of adult social care and public health, actually my incentives are really strong to invest some marginal resource in prevention that's going to realise gains in social care. So my incentives, for example, to use some of the ring-fenced public health grant in falls prevention activity or social stuff, interventions that are promoting social connection or interventions promoting physical activity in older people, my incentives are really strong. Now, some might criticise that, saying I'm moving some of my investment downstream. I should be really using the public health grant more upstream, more on some of the structural wider determinants of health and well-being. And there's no easy answer to this, so there's not a right answer. But I'd say the benefit of my position is, whereas I think adult social care directors who don't have the public health budget would have less room and less ability to invest in some of those downstream prevention, evidence-based prevention initiatives that I'm able to do.
Laura, do you want to just comment on the relationship as far as you see it from care home provision and its local authority, and where they're embedded within the local authority structures, and and how does that make research either easier or harder?
Thanks. Yeah, I was just going to come back also a bit on what Jason had said about the incentives and the challenges when you're working across a big system. And I do think that it is all about the levers and who is accruing the benefits, but also who pays, because you're sort of saying we're doing this, but the public health budget pays. But often the beneficiaries may be the NHS, or it might be industry in the case of care sector. And I think there really is something about the way that we do health economics to make sure that the monetary gains are being accrued in the right places, and that we're really transparent about that. And we did a trial at the end of the pandemic, and what we really wanted to look at how things like testing care home staff would benefit the care homes themselves. And so things like, if you keep the care home open, it means you can keep bringing in new residents. That means no loss of income. You don't have to go and pay lots of sick pay. But the way that we do health economics isn't really set up to do it in that way. That's much more a sort of business case plan. And so if anybody knows a health economist who does do that, I'd be very interested to know. But it just shows that the challenges of when you've got these things that span across different systems that are all funded in different ways, how do you work across that effectively so that we maybe get the NHS to pay for some of this, we maybe get industry to pay for some of it?
I mean, much of that was supposed to be addressed at the, with the, STPs, ICBs, or with the, and even if it's forerunners at potentially, in the PCT days, but at least at the moment, ICBs, have a central pot of money that's supposed to provide for all across health and social care. If you were to, so the structures are potentially in place. What needs, in your view, needs to happen to improve actual delivery that genuinely integrates health and social care from a delivery, but also research?
Definitely not for me.
So a big part of it is about incentives, really. I don't know anyone who works locally who doesn't want to work together. Integrated working to me at its root is about people who work with the same people coming together and working collaboratively, sharing information, sharing insight, expertise, data, not asking the people to repeat their stories multiple times, thinking collectively about how to problem solve, all of those things. And everyone working, most people working on the ground locally wants to be able to do that. But our system incentives don't always align and make that work. And it's links to the wider prevention point, and particularly, what I think ICBs haven't been able to achieve, and who knows what's going to happen with the next iteration of 10-year plan and etc., is to change the incentives within our health system, and particularly the incentives that drive behaviour in acute trusts, which just haven't, again, it just hasn't, we in an incredibly centralised top-down system that we have in the NHS, we still haven't managed to create the right conditions that encourage that kind of behaviour, encourage behaviour to keep people out of hospital. So I think ultimately, leadership will be the thing that creates the conditions in which people come together. The dialogue currently going on around neighbourhood working, which is incredibly strong in the NHS, there's a very, very powerful discourse about it, but the NHS has got a really strong track record of creating powerful discourses that don't end up in kind of meaningful change for people. And I think there's still a lot of questions about how that neighbourhood model is going to be really resourced and really create a different kind of different models locally in a very, very meaningful way, not on the surface, but really meaningful change, and change, like I say, that drives in particular change behaviour from hospitals.
Yeah, I think I have half my clinical work is in a hospital and half of it's in a community trust, so I sort of definitely see it from both ends. And the hospitals are just a hugely resource-intensive environments, and it's not always deployed in the people that need it the most, and that's just shuffling the ones that need it from the ones who don't. It's but also having integrated systems that allow one to not. To me, there is huge power in actually. In governance structures that span settings. So, for example, I'm no better an acute physician than my consultant colleague. However, if you have a facility whereby you can discharge people where you know that you are you're not just handing it over to a GP to sort out them, but you can take the responsibility. You can discharge much more riskily because you're actually responsible, and you have resource in the community to actually pick that up in a live way. So you can improve that. And my consultant colleagues who don't necessarily have that advantage will say, "Oh gosh, I'm very happy for them to go home." But great that you've got the power to follow them up. And similarly, GPs who know that they don't necessarily need to go into hospital, but are not in the right position to be able to treat acute stuff in a hot way. We need to have much more ability to operate across structures and settings, and let money and resource flow with the need.
And I think one of the challenges in the system right now is that everyone's struggling. Is that a system in some senses, a crisis should be a burning platform for change. But it doesn't always work in that way, because people haven't got the pressures are too acute. For example, in our local hospital where there's an enormous amount, like across the country, enormous amount of corridor care going on and desperate need for beds, the pressure to push people quickly through the system feels so acute, and actually would take a lot of both bandwidth, thought, capacity and bravery to say, hold on a sec, can we do things in a different, more sustainable way, which actually may be a bit slower in the short term, but may have proper gains in the long term. And it's how we, in this moment, which is really challenging, how we try and create the conditions where slowly we can make some of that happen, and give people that sense of permission and safety to kind of change their behaviour a bit.
I think we can open up to questions shortly, but I want to just propose maybe a transformative thing. I know you said there are lots of easy wins for prevention and so on, but it seems to me that given given that we now in an era where data, transformers allow us to synthesize vast quantities of data. I'm not going to say, although the capability is new, the problem is obviously old, and which is about the governance to share across different systems, because we can genuinely have communicate in central platform and updated data that's the notes that are synthesized for patients and clients directly live at any time, resynthesized, and a common set of documents that, or even a common transformer that follows with all your health and social care data. Where is the bravery for that kind of initiative going to come from? Because the gains are really super apparent, aren't they? That's very public
I think people are really keen to, and I don't think there's a. I think people would like to do that. I think what people also need to see is those real benefits coming from it. Because I think as much as there's real gains to be made from all of what you said around and linking data and identifying people and risk early. That's not a solution in itself. And I'll just give one example. We have in Newham incredibly good outcomes in terms of reach of our NHS health check programme. Really good. We reach loads of people, loads, some of the highest proportion in the country. There's no particular evidence right now that the outcomes of that are particularly good. So what happens, people have a health check, but actually what happens next, which is the intervention, which identifies the risk, the interventions that follow don't seem to be making a profound difference to people's health. So it's absolutely necessary to identify risk, but it's insufficient on its own if it's not backed up by the right interventions which follow.
I really couldn't agree more with that point. I think it's so undermining the idea that you just have data, you give it to someone else, you represent it in a different format, and some magic happens, and suddenly the world is better. And it really, but every time somebody does that, it makes it harder to then make the case for why data could make a difference to someone. So I do think this is a good example of where research is so important, because you need to lay on the algorithms, but it's not just the algorithm, it's then how do you present the information in the right way to the right people. So there's a lot of work that needs to be done around that. But if you can do that, there's huge potential to improve things.
Yeah, thanks. And I think most of the shifts that we've seen about, in Epic or other electronic records that we use, as service providers, it's normally those algorithms are there to make our lives as people that deliver care much easier. But actually, what about makes patients' lives easier? And, why couldn't you just say, well, I'm going to have my records extracted for me and my family at an education appropriate, culturally appropriate synthesis for me? That would be a fantastic way of showing people that their data are actually useful to them. Because it's not just, if you've ever been in hospital and you've got your own copy of your discharge summary and you're not a healthcare professional, a lot of it might seem quite abstruse. Even if you are a healthcare professional, it's not always clear what they mean. So I'm going to open up to panel to any questions. Roving mic. Hello. Oh, this one's turned on. All right, okay, so I can share.
Let's just...
Right. One question up there.
I'm going to give you both of them to try.
Hello, really interesting conversation. My name's Abiola. I am a non-executive director for an NHS trust, so understand the NHS space. Used to run a residential care, domiciliary care, so I understand the social care space. And now I represent lots of voluntary sector organisations. And so, when we're talking about the changes that we're all looking at in the NHS, meant to moving from hospital into community, from treatment into prevention, what we've talked about, don't you find it almost deafening that we're not talking about actually resourcing the voluntary sector who are actually out in the community and know the answers already? Do you not feel that it's a bit of a wasted opportunity that we're talking about all of these things, but we're funding the NHS, creaking and overwhelmed? We're not really funding social care, but we're trying to think of how we make that work. But no one seems to be talking about funding the really easy, low-hanging fruit, the voluntary sector. I just want to get your thoughts on that.
So I haven't really talked about it because of the way the conversation's emerged, but community and the voluntary sector being obviously a lot of the way in which community organises is a huge part, has to be a huge part of the answer. Both, you know, if we're really going to support people to thrive, to live well, to live their best lives, actually people do that in the way that they connect locally and support each other, and that happens. And that's a hugely important part of the picture. In Newham, we've invested a huge amount over the last few years in those relationships, in those partnerships. I've got colleagues here who do it day in, day out. Pointing. So I'm going to give you an example. So Rashpal's sitting over there. Rashpal works in the team in Newham, and one of the things that we developed over coming out of COVID was an older people's vitamin D program. So we have a hugely diverse population in Newham, and there was identified a need that we would really benefit from having a vitamin D supplementation program for older people in the borough. That's really, the vitamins are very, very cheap for us. We could afford that. What we couldn't do is really distribute them. But actually, there was a real desire from our voluntary and community sector to be involved with that. So what Rashpal built was this incredible partnership of, I think, 40 plus organisations across the borough. Am I right, 40? 45 now. 45, which is faith communities, community organisations who want to work together with us with common purpose, who want to be able to support their own communities, who build relationships, who know people at risk. And we have this incredible network, which isn't just about providing people with vitamin D supplementation, but actually having meaningful conversations about ageing well, about health in older life with our community. So it's just one example of what we can do. The challenges are, firstly, there isn't a lot of resource to go round, and money-wise, so it's about how we can be really thoughtful and in our use of resource, how we can try and unlock in clever ways more money to support that voluntary community sector, where we're going to target their efforts, and in a highly diverse place like Newham, where there's dozens and dozens and dozens of different communities, really thinking carefully about how we do that. But I think from our point of view, what we've done really strongly over many years, 5 years I would say now, is built partnerships and collaborations based on common purpose, because absolutely no part of the system can do this on their own. So there's loads we need to do. I think it's about investing in common purpose, in relationships, and then trying to unlock resource where we can.
But in a sense, to kind of go back to what you said right at the beginning about the different organisations, it does sort of strike me that that's not fair, because there should be funding for those kinds of activities, and it might be that those kinds of activities are actually way more impactful than many of the things that are being funded by the NHS. And so I think there's something also, and this is a bit utopian, I don't know how you would do it, but about being able to quantify and monetize the contribution from these different sectors and work out where you get the biggest bang for buck and then invest there. And again, I mean, that does, I'm broken record, but that does bring you back to data and being able to understand how people move across the system and which organisations are having the biggest, making the biggest contribution and impact. So I do think there's some work to be done around that too.
And the challenge is the reason, most of the money goes in presenting acute need, right? That's, and so what to shift money upstream, you either need some extra money, and sometimes we have bits of extra money and we can do it then, or we have to stop doing some of that meeting acute need, whether it's in health or in social care, to shift resource upstream. So that's why we have this system, which you're absolutely right. There's a kind of a system failure, which we are totally geared towards the overwhelming amount of our investment being that. Just to give a sense of that, so quantify that in kind of pounds terms, the public health budget in Newham is around £35 million. Still, most of that gets spent on kind of treatmenty stuff, sexual health and substance misuse. It's not really doing upstream work. There's probably maybe, a third of that at best doing kind of upstream work. And that's for a population of, like I said, of about 370,000. The social care budget is in excess of £100 million for 4,500 people. So that's the imbalance of resource that exists in the current system. Yeah.
Hello, thank you for that really interesting talk. My name's Cheryl. I am a GP registrar on my public health rotation, so I'm still quite junior in my medical training, even less out of my depth in public health because this is a very short placement. But it was interesting listening to the discourse between, there is a lot of acute need with the elderly and frail population, and I think regardless of how much we are able to prevent with preventative stuff earlier, there will always be that. And where I'm working at the moment, I'm not sure across other boroughs, we do have systems called like rapid response, so sort of intermediate teams made up with paramedics and other medical professionals that can assess people and prevent sort of acute hospital admission where is needed. So there's things like that, and to intervene at an earlier stage would require a lot of physiotherapy, occupational therapy, to assess our frail population. So I think what I'm trying to say, a lot of the preventative stuff from my point of view seems to integrate a lot of healthcare at a very basic level. And like no matter how far you go, there will be use of the multidisciplinary team, so nurses, specialists and physiotherapists and all those kind of things. So when we talk about prevention from a public health point of view, what does that actually mean, and where are the what's the difference between a clinical, like a health approach and a public health approach, if that makes sense, like local authority versus NHS? How can those kind of interact? And yeah, I don't know if that makes sense.
No, totally. Well, I'll have a go and tell me if this works for you. Because the way we tend to think about prevention is at different levels. So we have kind of whole population prevention measures which try to reduce risk across the whole population, what we might call kind of primary prevention, and those are a lot of that is kind of policy and legislation or universal services that try and reduce risk overall. Then a lot of what we're trying, I think when we talk about prevention here, a lot of what we're talking about, we would think about secondary prevention. So identifying people with risk factors where we want to try and intervene based on those risk factors to reduce the chance of X event or condition happening or condition occurring. So a good example would be the work that we're currently doing on falls prevention in Newham. That's trying to identify, that's not a whole population intervention. We're trying to identify through our health and social care system and through community partners as well, people who we identify as at risk of experiencing falls, and then take them on an evidence-based falls prevention program to reduce the risk of that happening. And actually, for it to work really well, and cost effectively, really does. We do need to identify kind of the right people, and that does really need that health and social care and public health integration to work together. If I just implemented the model on my own as public health without working with GPs, without working with our community health trust who are seeing people day in, day out who may benefit from it, I wouldn't know where to go. The risk is I'd just put the intervention out and it would go to people who are probably generally well. But it's by working together as a system that we identify those people who are who will benefit most. And then the other thing is I think that prevention mindset can exist at every level. Even people who are pretty unwell, that kind of tertiary prevention that reduces that risk of their situation getting even worse. There's all kinds of things we can do at every level of someone's journey to prevent their condition worsening. But I do think it's a mindset. It's a mindset which is different from a kind of a management of someone mindset, which is how do I kind of keep you stable, which is how do I help you to try and what's going to make a difference to you thriving. An example from a care home that I might take is this brilliant thing that I've seen, which is a hand bike intervention, which allows people to use virtual reality to go on, do some exercise with a hand bike and do it with a screen that kind of helps them explore the countryside. That is going to help people both physically and psychologically to really thrive in different ways. The alternative, the management, is just having them kind of sitting there but actually, so that kind of prevention mindset, that supporting people to thrive mindset, I think can exist at every bit of the journey, from that wider healthy population, primary prevention, people with risk factors, secondary prevention, people who are receiving a lot of care already. It can exist at every level.
Thanks. Yeah, I think it's a bit of a worldview as well. I have quite a lot of sympathy for what you said, because I do sometimes struggle with this idea that how far back do you go? And you say, so let's say we don't want people to go into care homes. So actually what we need is people to be fit and healthy when they're 20 years old. I mean, this resonates with what was being said earlier. So it's the interventions in those kind of age groups. But if you want to do those studies or those interventions, first of all, they're really, really hard. Second of all, to try and evaluate them and show they work. So it gets really difficult, whereas you can do a much more close to outcome kind of study where you say, well, if we give somebody anti-diabetes medication, then they have fewer heart attacks and there's a benefit. So I do think it's a bit about a mindset and how you think about, and that's a challenge. And as a public health person, you have to be very optimistic about that, because otherwise you couldn't do it. But then to give you a sort of more concrete example, I was in a care home recently, not as a resident, it was amazing, because they are really trying to prevent the decline of dementia. Really, really trying to do that. And so what they do is they have these kitchens where people with proper dementia, advanced dementia, are allowed to make their own tea. So there are all sorts of health and safety nightmares there, as you might imagine, about boiling water, but they are determined that they don't let people lose skills rapidly. And that's much harder for all the staff, but actually it does prevent the decline. And so I do think there are things that can be done, but often it is the harder thing to do those things, and so they don't happen.
But that's a great example, and I think the other aspect of it is harder for staff, but staff really like it. Workforce really like people when it go into public service to help people to live good lives. And those kinds of approaches, and we see it in all kinds of different ways, speak incredibly powerfully to people, resonate incredibly powerfully with our workforce about what they want to be doing. And I think the workforce are real allies in trying to do work which is supporting people to live good lives, to be independent, to thrive, to delay onset. So I think there's an open door. If, going back to your word of earlier, if we can be a bit braver about the kind of work that goes on within some of these settings.
Thank you. A really interesting discussion, and really great actually to hear a little bit more about the workforce, which was kind of going to be one of my questions. But I'll move to the other question, which was really about data collation and data sharing, and whether you could talk a little bit about any challenges specific to adult social care. So, for example, for the health system, we know that there are health opt-outs. These apply to data obtained for national data sets, for example, through NHS England. Do you have equivalents? Are there obstacles, and how might you overcome them sort of in the adult social care space? I'm really thinking about how you build whole population data sets that include this kind of information.
I think the truth is I'm not the best person to answer that one. I think I'm probably not the best person to answer that one.
So on the opt-out question, so my understanding, again, only for care homes I can speak to, that if you are local authority funded, the opt-out applies, but if you are not local authority funded, it doesn't. And so that obviously creates all sorts of challenges in terms of implementing that, because in most residential nursing homes, you have a mixed population. So the approach that we've taken is we've given everybody the option to opt out, just because we can't do it for some residents and not for others. And that's been workable via CAG applications and with obviously a lot of co-production and PPI to support that.
Just going to say that. So I think one of the, just to synthesize some of the things, the ideas that have been floated, I guess, local authority, we've heard that having a central forum for lots of voluntary sector, faith-based group to actually be part of the voice, both afferently and efferently, feeding up to local authority, but also being effector arms for the local authority. Public engagement, co-production, all of these things are going to be the elements that lead to a whole population approach. So these are my data, these are what I'm happy for, and having the ability for users, practitioners, workforce, and people in the workforce are still also users. I go to the doctor too, right? So enabling that infrastructure where all of those conversations can be surfed in an authentic and way that speaks also to potential inequalities. I mean, it's potentially complicated, but isn't that sort of part of the vision? And once you have that in place, well, then we have data sharing party, and we'll be doing ChatGPT left all day and every day, etc.
I think on the data issue again, a real challenge is that in the NHS, in healthcare, we have not perfect data, but relatively good data. And so for a politician, they can very happily give you statistics on hospital admissions and waiting lists and all this kind of thing. But because we don't have the equivalent for social care, it is a massive disadvantage for users of social care. And the problem is invisible and easy to ignore. And I think that there needs to be a real shift in how we think about data sharing for populations that can't advocate for themselves in the same way.
Hi, great to hear you talking about joining the NHS with environmental health inspectors. I am with a party of old EHOs. And one of the things that strikes me is the BRE report on the cost of ignoring poor housing. We've got 2.4 million houses with Category 1 hazards. All of these things help the elderly and cost billions every year. It would cost far less if we actually repaired those houses. Now, the budget for it, the NHS is telling us how bad it is, all these old people turning up in the winter and other times with the various issues that relate to climate and heating money and the rest of it. Where is the political push? You're trying to do some things across this area, but it's a big government push. If we put 9 billion into doing up the 2.4 million houses, we'd cut that forever.
I didn't hear, you weren't given the best quality microphone, so if I'll just summarize what I heard, if I may. It was really about the preventative aspects for the relationship between housing and health and social care use. And we've talked a little bit about housing tenure and how that may or may not be a local authority responsibility, but any thoughts on housing as improving housing to health and social care prevention?
So it's a huge, you're absolutely right, it's an absolutely huge determinant of health, and in the area I work it's a huge factor on so many different levels. It's obviously a challenge, a very, very costly challenge to address on a macro scale. I mean, I think that's part of the challenge, and if I take the area where I am, we have huge housing issues across the whole life course. So, tens of thousands of children living in overcrowded accommodation. We have huge energy efficiency issues and fuel poverty issues. Lots of people living in cold and damp homes. We have an increasing homelessness population, and we've currently got 7,000 households in temporary accommodation. That's well in excess, going to be well in excess of 20,000 people living in temporary accommodation. And then, as I mentioned earlier, a lot of older people across all tenures living in very, very poor quality accommodation, whether that's council, owner-occupied or private rented sector. It needs a huge amount of investment. I think ultimately it would, as you suggest, it would be highly cost effective to the system as a whole. And as we mentioned earlier, one of the challenges we have is that we're not very good at recognising system costs and investing collectively to address those system costs. I guess all I would there are levers and tools that we try and use at a local level to try and address it. So, for example, in our adult social care team, we have a really, really effective occupational therapy service. We do home adaptations where we think we can make a significant difference, and use of things like the Disabled Facilities Grant that can make a difference to people's day-to-day living situations, that can make a meaningful difference to people's health and well-being and quality of life in a significant way. We have a landlord licensing scheme which tries to raise the overall level of conditions within the private rented sector, which is much worse than the social sector, the sector where there's the highest levels of housing vulnerability. So there's, in all ways, in public health, the question we ask at a local level is, what are the tools and levers we have at our disposal, and how can we maximise the levers that we have to make a difference? So some of these issues require really significant national investment, but that doesn't mean we kind of act helplessly and we try and pull the levers that we've got access to.
As the Chief Medical Officer for England, Chris Whitty, says to ministers who he speaks to probably daily, you've either got politically difficult or you've got expensive. So we've only got 5 minutes left, so I wanted to ask my panellists what they do at the end of in our time, which is, what are the questions that you weren't asked that you wanted to have just a couple of minutes to say something about?
You go first.
What did I want? I guess the only thing I would say is that as we're at UCL, doing research in social care is a really interesting area to be in, and there are massive opportunities, and as somebody who's worked mainly in the NHS previously, there's a lot more freedom. And so if people are interested in these kinds of questions, I would just urge you to consider it, because it's a really exciting, and there is a lot of need for research in this area. So a pitch for recruitment.
And thanks, Laura. And I'll take the hint, and as we're in UCL, I'll also focus. So, one of the things we've not spoken an awful lot about in this session is about diversity and inequalities, and about working as I do in Newham, which is a hyper-diverse place. One of the things that we think about deeply is about how policy and practice works effectively for the diverse communities that we work with. And as we came out of the pandemic, the council, working with Graham, with UCL, with other local universities, decided to set up something that's called the Newham Centre for Health and Care Equity. And the point of the Newham Centre for Health and Care Equity is build bridges between academia, local authority, NHS and community to do meaningful research that makes a difference on inequalities in people's experiences, to generate actionable insights from research to make a difference on the ground. Because one of the things time and again we saw through the pandemic was that national policy applied decontextually to a place like Newham is full of problems and issues. So we've set that up. What we're creating is a really, I think, thriving ecosystem of relationships between practitioners across all aspects of healthcare and the wider determinants of health, and interested academics who want to work together on meaningful projects. As Laura said, social care specifically is a really research-light area. We are not informed by a lot of research compared to healthcare. There is a tiny amount of research that goes on. But even more broadly into the wider determinants, every day as a local authority, we spend millions and millions of pounds on the determinants of health and well-being. There's action going on day in, day out across a wide array of areas, things I've mentioned from landlord licensing to occupational therapy to regeneration programs to all things which could be subject to really, really meaningful academic partnerships. So if you're interested, come and get involved with us in Newham.
Thank you very much. And I think the last thing I was just going to say is, given that the spirit of all this is about working across sectors and integrated strategies and so on, I think I would have liked to have heard a bit more about a common idea to sustainability in healthcare and health and social care and climate change and so on. So thank you very much. That's the end of the session.
Thank you, Daniel, and we'll take your suggestions for our next symposium. Really, really wonderful conversation, and thanks, Laura and Jason, for stepping up and sharing your thoughts with us. I'm now going to thank the speakers and introduce our chairs of the Early Careers Network. These are Louise and Peter. There you are. Please do come up because you are going to be talking about the posters downstairs and the winner of the prize.
Hi everybody, my name's Louise McGrath-Lone. I'm a co-chair of the Health of Public Early Careers Network. So one of our roles is to champion early career researchers who are working across the health of the public at UCL. So you've already heard from two fantastic ECRs in the early years and older years sessions, and there's some great posters downstairs to have a look at as well. So if you thought that the oral slots were hotly contested, I've never had to elbow my way through posters to judge them before. So there's a fantastic array of topics, and the standard of work was amazing, both in its rigour and in its communication. So second prize goes to Robin Jones for a poster about social connections and trajectories of multiple long-term conditions amongst older adults. So that's poster number 1 downstairs if anyone wants to look later. And first prize goes to Kerry Stevenson for a poster about engaging the less often heard in public health research grant writing. Thank you. And so I'm going to hand over now to close the session. Yes.
I'm delighted to introduce Professor Jennifer Hudson. Jennifer is Vice Provost Faculties and has kindly agreed to say some closing remarks at the end of what I think has been a wonderful day. Thank you, Jennifer.
I know in this position you're the last between either fresh air and drink, so I will be brief. My name is Jennifer Hudson. I've been at UCL for about 22 years. I am a political scientist, so I'm not a public health person. But I caught this last session, and I was really interested just to hear Laura and Jason's final remarks on partnership, on the role of public health here at UCL, the need for social care, more on social care work going forward. I am Vice Provost Faculties. What does that mean? It means I work with the 11 faculty deans at UCL on our academic mission, so our research, our education, and our external partnerships. I think what's been lovely from what I've seen today is the genuine interdisciplinary approach that public health takes to addressing these really important and challenging questions that are in front of us. UCL is undertaking something that we're calling our academic ambition. And for us, that question is, as we come to our 200th birthday next year, what is it that UCL wants and needs to do to address some of these big questions like public health? What's come out of the voice of the community as we've gone around and talked to different faculties, deans, academics, lecturers, teaching fellows, is the need for health, which we do so well at UCL, to continue to go forward, to continue to be invested in, so that we can take the things that matter to us our families, our communities, our friends, the health and welfare and economic vibrancy of not just the UK but the world forward. So thank you for the work that you do. It really is a public good, and we're all better off for it. I want to acknowledge the ECR work. I had a very quick, brief look at the poster, so congratulations to the many ECRs who are here and bringing their research to these symposia and getting that exposure and that engagement. Thank you very much to the presenters and to the chairs for today. It's really great that you have joined this group and shared your expertise. I know there are academics in the room, there are practitioners, there are medics, there are those of you who've joined from outside UCL. So thank you very much for joining us. I think there's a reception outside. Have a good rest of day. Bye-bye.
So thank you to Jennifer for that. Yes, I'm standing between you and a decent cup of tea, I hope. Just to particularly thank some of the organisers of today, that's Rachel, Fran and Sarah, without whom this wouldn't have happened at all. So my warmest thanks to them. You have the opportunity to give feedback. There's a questionnaire online. Please do, however you wish to, send emails to us about how you've experienced the day. Any suggested changes, we'd love to hear for next year. Please leave your badges at the door. We recycle, reuse those, and just enjoy the rest of the afternoon, a good cup of tea, and an opportunity once more to undertake some further networking and engagement with the wonderful audience here. And I must also thank the audience online sending in questions and attending throughout the day online. So thank you very much.